the closet and your boy trying to study. So that's what we finna do. Yeah. You don't really get a lot of time to study here, bro. You just gotta roll with the punches. You know what I mean? But yeah, your boy got his Sharpies out, ready to go. I'm gonna just put it down. So if you see me highlight with this, vocabulary. You see me highlight with this, definition. You see me highlight with this, we got a problem. All right. Now, and there's another thing I have to remember is BSI. The scene is safe from my battling eye. MOI or NOI, which NOI is nature of illness. MOI is what mechanism of injury. And you want to have additional resources or additional EMS on standby. Then you want to consider C-spine. Yeah, all right, let's get it. So I'm in chapter 14, or no, chapter 15 now of this book. It's a nice book. All right, so related chapters, I don't care about that. Core concepts, secondary assessment, and responsive medical patient, secondary assessment, unresponsive medical patient, second assessment, trauma patient and minor injury, second assessment, trauma patient with serious injury, and multi-system trauma, detailed physical exam. Okay. So the outcome of this, you want to be able to describe a secondary assessment. Describe a secondary assessment into the overall patient care process. Describe secondary assessment of medical patient. Okay, let me highlight this. Describe secondary assessment overall patient care process. Describe secondary assessment of medical patients. Describe secondary assessment of trauma patients with serious and multi-system injuries. And analyze your approach. Analyze your approach to decision-making in EMS scenarios. So we got some key terms here. Detailed physical exam. Distension. History of the present illness or injury, HPI. Medical patient. That's, a given. I probably shouldn't have highlighted that. Paradoxical motion. Past medical history, PMH. Priapism? What the heck? Okay. Rapid trauma assessment. Gotta get them, gotta go. A reassessment, if you got extra time like that. Sign. Stoma, that's what you breathe out of if you smoke cigarettes. Symptoms, what the patient is showing. Tracheostomy, trauma patient. All right. Secondary assessment. All right, so a medical patient is a patient with one or more medical diseases or conditions. Trauma patient is suffering from one or more physical injuries. An unknown patient is a patient with a problem of undetermined nature. Alright. So a medical patient, medical disease or conditions. A trauma patient suffering from one or more physical injuries. The history of a present illness. Information gathered regarding the symptoms of the nature of the patient's current concern. All right. I feel like we're doing good. Your boy got till 7:30. All right. So we roughly got an hour or so because I gotta get ready, pack up all my school stuff. Your PMH, your past medical history, is information gathered regarding the patient's health problems in the past. All right. And then walking through a freaky thing. A symptom is something regarding the patient's condition that the patient tells you. That's nice. Okay. And then a reassessment is a procedure for detecting changes in the patient's condition It involves 4 steps: repeating the primary assessment, repeating and recording vital signs, repeating the physical exam, and checking interventions. Okay, okay. Now we're going places. Sometimes I really just be like, how did I get here? But other times I'll be like, you know what? I'm not dumb. I got this. And other times I'll be like, hey, I'm kind of dumb. I don't know if I got this. All right. Core concept, secondary assessment of the unresponsive medical patient. Responsive medical patient. Oh, okay, so I need to know how to do that. Alright. And look here, you get some nice pictures in the book. Gotta show it to the kids. What is he doing? She's telling him why she called, pretty much. They're trying to get her freaking past medical. He's doing freaking a physical examination, and he's checking her blood and doing her vital signs. Yeah. Oh, where's my freaking... I got a paper with a bunch of acronyms on it. Well, you got onset, provocation, quality, radiation, and severity and time. You got op, q, or st. Then you have sample, which is signs and symptoms, allergies, medications, pertinent past history, and last oral intake and the events leading to the illness. Yeah. And then there's a table here, which is responsive medical patient. Gather the chief complaint. Yeah, get the chief complaint from them. Gather past medical history. Conduct a physical exam, and then obtain baseline vital signs. Okay, so there is a difference between freaking someone who's conscious. There's a difference between somebody who's conscious and unconscious. If they're awake or slumped, all right? If they're responsive, you want to take that time to get as much information from them as possible. But if they are freaking, on the floor and you don't know what happened, the first thing you want to assume is that they're probably dead. So you want to, check their head, neck, chest, abdomen, pelvis, extremities, and posterior, their back. And conduct a rapid physical exam. You don't want to spend too much time on that because, the patient's probably dying, you know what I mean? And you want to obtain baseline vital signs, their respiration, pulse, skin, pupils, blood pressure, and oxygen, or RPSPBO. Yeah. And after that, that's whenever you would get their freaking history from like their family or something, or if they wake up, you know what I mean? And then finally, you want to gather past medical history. So you want to get information on their present illness first, and then you want to get their past. It's kind of like being in a relationship. You get to know them as who they are, and then you worry about who they were. Because they could kill you in your sleep. You never know. That's deja vu right there. Oh my goodness. Why am I having deja vu in the closet? All right. Examination of a responsive medical patient. Intervention to perform intervention as needed, and transport the patient. Contact online medical direction as needed. Online, which is like, having a conversation with somebody on the other end and they're walking you through what to do. While offline is, you're looking at a book. Tailoring physical exam. Perform a physical exam, obtain baseline vitals. Yeah, we walked through that last chapter, but you guys are bozos, so we'll do it again. To complete a set of baseline vital signs taken during the secondary assessment is initial to the assessment of a medical patient. Later assessments of the vital signs will be compared to the assessments of the medical patient. Later assessments of the vital signs will be compared against the baseline of the vital signs to determine the trends of the patient's conditions, trends in the patient's conditions. And if you're using a automatic blood pressure device, you should also take a manual blood pressure to verify the accuracy of the device. And again, at any point, the device reports a significant change in blood pressure. You always want to make sure that they're either staying the same or getting better. Well, more than likely, if they had to call emergency services, they're not going to get better. But on the chance that they do, that's what you're looking for. But if they're getting worse, that's whenever you have to start applying stuff. You know what I mean? So a type of complaint would be a cough, fever, chills, dyspnea or exertion, weight gain, or has prescribed bronchodilator. Physical exam, you would do lung sounds, and you would pretty much look for wheezing, work of breathing and position, pulse oximetry. Oh, you want to look for their oxygen saturation. How many freaking clown cars can you fit in a vein? Pedal of sacral edema. Chest pain or discomfort. As prescribed nitroglycerin, taken aspirin. Skin color, temperature, and condition. Yes, you always want to make sure that the patient's skin color or skin, and you want to check for 3 things on the skin: color, temperature, condition. Because, okay, everybody has white hands. Everybody has white little fingernail things. Skin under your fingernails. If that's not right, like if it's blue, if it's freaking gray, if it's pale, or if it's freaking yellow, that's not good. Especially on your lips. Your lips too is a good sign. So yeah, you definitely want to check that. So after you check their skin, you want to check their blood pressure, check their pulse, check their lungs for any sounds. If they have chest in their pain, pain in their chest. We already moved on from the shortness of breath. Yeah, if they have chest pain, then has prescribed nitroglycerin, is taking aspirin. That's irrelevant. You want to freaking check their jugular vein distension. Jugular vein distension. Ankle edema, which is swollen ankles. Oxygen saturation. Mental status changes of neurological complaints. Headache, seizure. You want to fast. Ooh, I know this one. The fast face, arm, speech time, which is it's more commonly what you would do for a seizure, or is it stroke? I don't know. But you want to check their body, make sure one side of their body isn't like this, You just want to make sure everything's okay. For the face, you want to be able to check, does one side of the patient's face droop? Arms, can the patient hold both arms in front of the patient? Speech, is the patient's speech clear and or understandable? The time is critical. Time is critical. The patient exhibits any of these signs, even if they go away, call 911. All right. So if somebody has an allergic reaction, the first thing you want to get is their time of exposure. Time of exposure. Because, if they've been on the ground for 30 minutes and they can't breathe, if they heart ain't stopped already, they probably dead. Time of symptom onset, which is when did the symptom first kick in? Or whenever you were exposed to it. A good example my teacher gave me was my boyfriend or my girlfriend ate Reese's and I'm allergic to peanut butter. And I kissed her. So I was exposed to it at the kiss, but it could have kicked in like 6 hours later. You know what I mean? Yeah. Check for a stinger. Check for a stinger. Rash, hives, lung sounds, always. Face and neck edema, so swollen neck and face. Yeah, yeah. And then oxygen saturation for an allergic reaction. All right, for abdominal pain, you want to check for fever, nausea, vomiting, nausea, diarrhea, constipation, blood and vomit or feces. You never know. Bright red, fresh or dark digested. Okay. Menstrual history. All right. So altered mental status. This we use a thing called AVPU to tell like how awake a person is. You know, A is alert. Like I walk up to you, you're already making eye contact with me. V in AVPU is verbal, which is like they're like laying on the ground. I say, "Hey, wake up!" And you know they look at me. They're like, "Oh, hey, what's going on?" Or like even if they don't say anything, they notice me whenever I speak. Pain, they're only responsive to pain, like me pinching their earlobe really hard or church pinching them on their freaking thing. And after pain is unresponsive, which means they don't respond to anything. But yeah, and whenever it comes to altered mental status, the first thing you want to get from them or anyone around is when's the last time they ate, their medical history, like have they had this kind of situation before, or recent illnesses that could cause this. Like I know if your body isn't cleaning itself right, then everything that's not getting cleaned properly will just like keep circulating through your body, and then it goes to your brain, and then now you're freaking screwed because you're going to be talking to a bird and killing you. Excessive hunger, thirst, urination. Bro, I have to carry 3 liters of water on my back every day and probably refill it like once or twice throughout the day. I be urinating. You want to monitor their blood and glucose. You want to check their skin color, temperature, and condition. That's what we just talked about. And mental status. You know, that's kind of a given. Oh, diabetic history. Oh, I didn't even see that. See, my patient would be dead already. Their mental status and unusual breath odors. Your boy breath just be stinking. It's crazy. I'm sorry. I think like an EMT challenges in history. I'm not gonna worry about that. But a pediatric note: when gathering history from a child, be sure to kneel or find another way to get on the same level with the child. Yes, children are very scared, especially whenever they don't know what's going on. Put questions in simple language that the child can understand. Like, I can't walk up to a freaking child and be like, "Oh, what's your sample? What's your sample?" And like, they're not gonna tell me. Sample is an abbreviation for something. Like, yeah. Note that much of the history for a child and all the information of the infant will need to be gathered from parents, guardian, or other adult caretaker. Boom. There we go. Point of view. What an EMS says. Okay. No definitions on this page. All right. So again, a rapid physical exam. You're going to perform a rapid assessment of the head, neck, chest, and abdomen. Pelvis, extremities, posterior. And you want to get their vital signs. You want to get their respiration, pulse, skin color, pupils, blood pressure, and oxygen saturation. I know, it's a lot. Ooh, All right, but let's go over that real quick. It's 6:30. We have an hour. Yeah. Respiration, breathing, pulse, blood flow, skin color, temperature. Make sure everything's adding up. Pupils. Make sure one eye isn't like this big and the other's like this small. Or like they're both tiny, but it's freaking like dark as heck, or they're big and it's dark. I don't know. Wait. It gets small when you flash a light in it, and it gets big when it's dark. So if somebody's flashing a light in your eye, it should not stay big. It should get small. And then their oxygen saturation, which is pretty much just telling you like how efficient their blood is flowing, like or how much oxygen is getting pushed out through their veins, which is kind of complicated sometimes because like certain other things can also go where that oxygen is supposed to be, like carbon monoxide, which is stupid. All right, and then you want to get their medical history. If they're unconscious and they're by themselves, it's a little hard. You kind of just want to like, if there's any pill bottles around, then you want to check that, see if like it may help you. Like if an unconscious person's on the floor and you don't know what they are, and you look around, you see a pill bottle, diabetes medicine, boom, they're probably having an allergic reaction. My first assumption. Bam, or maybe they haven't eaten, or the medical history. You want to interview family and bystanders for information about the present illness and the OPQ. Where's that? OPQURST. Allergic medication, allergies, medications, pertinent past history, last oral intake, events leading to illness. And intervention and transport. Sometimes you won't be able to transport them. Like if a woman's having a freaking child, you're not going to be able to move her. You're just going to play football. You're going to catch that baby when it comes out. But interventions, you want to know what the patient did to make the situation better so that you can do 10 times better to make the situation better. Next page. All right, medical patient assessment. It got pictures. All right, so if responsive, you're going to ensure adequate breathing, check pulse, skin signs of shock. Unresponsive, you're going to immediate ABCs, suction, airway, adjuncts, ventilation, if necessary, circulation. So like if they're, what's the scenario? Okay, so immediate ABCs, which is airways, breathing, airway, breathing, circulation. Airway, making sure that there's nothing blocking their freaking trachea. Breathing, making sure that their lungs rise properly. And circulation, making sure that the blood is going everywhere it needs to go. Ventilation, if necessary, which is, holding the bag over their face, squeezing it in and out to make sure they're getting there. And then circulation, check their freaking stuff, if they're responsive to supplemental oxygen indication. History first, body systems exam as appropriate. If they're unresponsive, body systems exam first, history, expedited pace. Upon approach, if patient appears lifeless and is not breathing, begin circulation and pulse check as a part of CAB. Okay, yeah. So the way you initially were supposed to do it is ABCs. You do your ABCs, you do freaking airway, breathing, circulation. But if they look lifeless, like if they look dead, you want to do CAB, which is circulation, air, and then breathing. Airway and then breathing. Because think about it. If they have no air, you have to give it to them after you check their pulse, circulation, freaking airway, make sure it's not blocked, and then breathing, make sure they're breathing. Vital signs. You want interventions in or out for serious or unstable patients. You got your crazy ex, she OD'd. Now she's trying to kill the EMS. You know what I mean? You got some crazy stuff. Transport, timing, priority, and destination based on patient's condition. As usual. I'm not going to take my patient to a freaking plastic surgery hospital if they have a broken leg. You know what I mean? Yeah. Open every 15 minutes. Reassessment about every 5 minutes for unstable patients, about 15 minutes for stable patients. Repeat primary assessment. Reassess chief complaint. Check interventions. Repeat vital signs. Notify the hospital. Provide a concise report. Notifying specialized teams, cardiac, suspected myocardial infarction, chest pain, or stroke. Yeah, you have some crazy stuff on me. Perform a rapid physical. I have to take this off, bro. My back hurts. All right. Oh, my back. All right. Let's keep it pushing. Yeah, I'm just seeing perform a rapid physical exam, neck, chest, abdomen, pelvis, extremities. Consider a request for ALS personnel. Yeah, if it doesn't look too good, and maybe even if there's like multiple people down or whatever, regardless of, let's say like multiple people caught a stroke at the same time, you want to call in you want to call in some backup. Check pupils, baseline, vital signs. Oh, wait, mid-chapter review. What the heck? Never seen this before. So some key facts and concepts, key decisions. All right, let's see. From what I just told you, let's see if you can get this right. Wait, key facts and concepts before we get in. The secondary assessment of a medical patient takes two forms, depending on whether the patient is responsive. You assess the responsive patient by obtaining a patient's history and performing a physical exam of affected parts of the body or before getting baseline vital signs. Physical exam before doing vitals if they're unconscious. To make sure you don't break anything if they're freaking, if their spine's messed up, you don't want to give him air, and you're messing up his spine while you're giving him air, Since unresponsive medical patients cannot communicate, it is appropriate to start assessment with rapid physical exam, what I just said. Baseline vital signs come next. Then you into interview family, friends, bystander, whatnot. You get the medical history. You might not change any field treatment as a result of the information gathered here, but the result of the assessment may be very important to the emergency department. All right. Key decisions. Is the patient responsive enough to provide a history? You don't want to ask your patient for history if they're broken neck, can't talk back, or they get their tongue cut out by the homie. If a patient cannot provide history, can somebody present at the scene do so? Wife, children, all that. What kind of secondary assessment does the patient chief complaint suggest? So, if they call you over and they're talking about they got chest pain, and then you get there and they're on the floor, heart attack. So, yeah. All right. Preparation for your examination and practice. Let's see what I've taught you. We still got time, baby. I'm a teacher today. I'm tired of being taught. I want to teach. All right. So, explain how and why the secondary assessment for a medical patient differs from the secondary assessment for a trauma patient. Okay, before you answer that, a medical patient is somebody with an illness of some sort, something wrong internally. When I can't really say that, can I? Something disease-wise. No, I guess I could say something that started from the inside or came in you through the outside of germs and freaking blood flow and all that. And then from a trauma patient is somebody who's taken an injury, whether it be a stabbing, a shooting, a baseball bat to the freaking head, or anything like them falling off of a roof and landing on a vase or something. Anything like that is physical harm from the outside, that's trauma. Anything that is harming you from the inside out is emergency. I mean, medical. I don't know. I'm not the best teacher, I guess. Explain how and why the secondary assessment for a responsive medical patient differs from a secondary assessment for an unresponsive medical patient. You already know. He was talking about this. If they unresponsive, you don't want to walk up to them and be like, "Hey, how you doing?" Because they're not going to answer. You know what I mean? But if they're responsive, even if they're a little loopy, you can get some information just out of them being loopy. You know what I mean? But yeah, you definitely want to get that information from their family or other people if they're unresponsive after you stabilize them if they're unstable and unconscious. All right, thinking and linking. You already know. I'm thinking about you. We linking tonight. All right. Think back to the scene size up, which is pretty much just assessing your scene whenever you get there. I link the information from that chapter with information from this chapter as you consider the following situation. You are at the home of elderly man whose wife calls 911 because her husband was complaining about his chest. Was complaining of chest pain. While assessing your patient, your wife begins to complain of shortness of breath. Now you have two patients. What should you do? BSI, the scene is safe for my battling eye. No, NOI or MOI, nature of illness or mechanism of injury. Extra resources or EMS on standby. Consider C-spine. All right. So I'm already dealing with one guy. He's probably having he said his chest hurt, so it's probably something to do with his heart. And then his wife having shortness of breath. She freaking out. Oh, my baby, he dying. He dying. She starts freaking out and she's hyperventilating, I guess. Let's see. Yeah, shortness of breath, she hyperventilating and all that. So at this time, by the time you reach the scene, you should have already informed standby EMS, which means you being somebody, you already are EMS. You're already there. So you and your battle buddy, your freaking the other person that rode with you here, it's you and them. Which most of the time, the most efficient way to take care of somebody is you and them taking care of one person. Now there's two people down. So now I have to deal with him and he has to deal with him and he has to deal with her. Look, this is patient one, patient two. Us two take care of this one. But the people that are, on standby, we call them up. They come take care of this one because it'll be more efficient if we have 4 people working on 2 people. Because, now we have multiple trained professionals on the scene. You know what I mean? Calling that back up always and forever. But you also do want to make sure that they're stable and take care of them up until that point where you're relieved by other medical professionals. All right. Then we got critical thinking exercise. Cool. Secondary assessment of a trauma patient. Okay. Not seriously injured. After the scene size up of a primary assessment. Is that more seriously injured? Yeah. Okay, so if they're not seriously injured, like they got a scrape on their knee because they fell off their bike, you want to determine the chief complaint. Ellis, El, Ellis, El, elicit, elicit information about how the patient was injured. Like, hey, I fell off my bike, messed up my ankle, can't walk home. They probably said that in the call, and now you're just asking more questions about that while you patching them up, making sure they could assess their baseline vitals. Make sure that they breathing good. Like you can tell if somebody's in pain because they'll be like, "Man, that hurts so bad," and their heart rate will be going because their blood's like, "Hey, that's not good. We should probably start patching that up." And then obtain their past medical history. Like if you got weak bones, that's probably why you broke your leg. Okay. And then for more serious, you want to determine the chief complaint. Yep. Continue spinal precautions if indicated. Like they got in a car crash. More serious. They have broken ribs or broken kneecap, broken something. Uh, Getting in a car crash is very easy to mess up your back. So in order to stop me from hurting your back even farther, what I'm gonna do is I'm gonna hold your head very still while we try to move you. All right. Advanced life support. So you want to get the big dogs coming in. All right. You want to make sure you want them taking care of you if it's something real serious. And if it's something like really serious, we'll like handle you till we get to the hospital. Perform rapid trauma assessment, which is like after we make sure your spine is good, after we make sure your head, neck, and all that, your chest, your pelvis, your freaking your everything up, head to toe. After we make sure you're good, then we're gonna freaking get your vitals. And then we obtain your patient history. All right, boom. Well, I'm kind of liking chapter 15. Massive hemorrhaging, airway, breathing, circulation. We got pictures. You want pictures? All right. Assess injuries that could affect breathing, apply oxygen or ventilation as needed, maintain the airway, listen and compare lung sounds, check for signs of shock, slower focus exams. Look, I'm gonna be real. You either have time to play or you gotta get out of Dodge. If your guy was in a car accident, he perfectly okay. Maybe his kneecap a little swollen. Then you got time to play. You can fill him out. You be like, hey, this hurt, does that hurt? What about this? Well, when's your wife leave? Like, you got time to ask questions. Get their mind off it. Just as much as your mind doesn't want to be on it. But if your patient got a freaking shard of glass about this big sticking out of them right here, and they bleeding out, and they've got blood squirting out their arm and everything, you don't got time to play. You gotta get them out of there fast. You gotta get them ready to go. And then you perform your detailed assessment, and then you notify receiving hospital. Bing bop boom. Yeah. Your spinal motion restriction applying to cervical collar. OCMS will apply cervical collar to any patient who requires spinal precautions assessing. Okay. Yeah, you want to get, like I said, if you get to a car crash and it looks pretty bad, you don't know what's going on, you want to assume their back is messed up. Or even if you just have somebody laying on the floor, you want to make sure their back is not messed up. Because if their back is messed up and you get to touching all over them, that's a lawsuit. That's why these precautions are here. But yeah. C-spine. Make sure their back is alright. You got the stiff neck, the whiz lock, the Philadelphia, the neck lock. Oh wait, no, I don't know. You got all different kinds of neck braces. But yeah, you want to measure the patient's neck, measure the collar, the chin, and make sure you have the right size freaking thing. A rapid trauma assessment. All right. A rapid trauma assessment of the head, neck, chest, abdomen, pelvis, extremities, and posterior of the body to detect signs and symptoms of injury. All right. That's for people who go through trauma. I don't know what this neck thing was about. We'll go over it in class. You guys are just here so I learn, okay? You're not learning right now. You're just listening so I can talk to you and I learn. All right. The guidelines for field triage of injured patients. Transport to a hospital that provides trauma care if the following is identified. Adult falls are 20 feet or more. Children falls are less than 15 years old or 10 feet or more. High risk auto crash, intrusion, ejection, death, same passenger compartment, vehicle telemetry data consistent to high risk. Auto versus pedestrian, bicyclist thrown, run over, or with significant pediatric note. Infants and children are more fragile than adults. This means that children may sustain the same injury as an adult from this force. For this reason, there are additional mechanisms of injury that EMT needs to consider significant when children, infants are concerned. Remember that because of children's smaller stature, injuries that could affect an adult's knee or thigh might affect the child's abdomen, chest, neck, or skull. Yeah, terrible. Children, why do you have to be so weak? Your baby bone boy. Keep kicking my phone. Alright. The lighting in here sucks, bro. I can barely read this. Bro got no clothes on. What's going on? Why are you just in the shit? Okay. Let's keep going. We got pictures. Look, that's me on vacation. Continue spinal precautions. Consider requesting ALS personnel. Reconsider transport decision. Reassess mental status. Perform a rapid trauma assessment. For wounds, tenderness, and deformities. Wait. Start from up here. A rapid trauma assessment. Rapidly assess each part of the body. You start from the head, check for wounds. Check for wounds on the face, check for wounds on the ear, check for wounds on the eyes. Check for wounds on the nose, check for wounds on the mouth, check for wounds on the neck, check for wounds. Application of collar once the neck has been. They cut bro's pants into jorts. Why would they do that? Once the neck has been examined, apply a cervical collar. Chest, inspect the palpate. Inspect and palpate for wounds, tenderness, and deformities. Make sure the chest isn't freaking caved in. You know what I mean? Other abdomen, check for wounds. Pelvis, check for wounds. Upper extremities, check for wounds. Upper extremities, check for wounds. Lower extremities, check for wounds. Lower extremities, check for wounds. Oh no, check for circulation. Okay. Vital signs, that respiration, pulse, skin color. Let me just highlight this, bro, because it keeps popping up. I know I'm going to need it. respiration, pulse, skin color, temperature, condition, pupils, blood pressure, oxygen saturation if directed by local protocol. Then you want to get their sample, their signs and symptoms, allergies, medications, pertinent past history, last oral intake, and events leading to problem. Interventions in transport, contact online, medical direction, and perform interventions as needed. Package and transport the patient. Bro, this ain't FedEx. We're not packaging anyone. And everybody can prevent injury. What's the point here? About the patient's mechanism of injury. Let me see the them in their bag. Remember to lift and look. Lift and look. Your boy got 30 minutes. So let's crunch this out real quick. Look, y'all thought I was joking. It was nothing but pictures, but it just kept reading the same thing. Like whenever you look at the head, look for wounds, tenderness, and deformation. And it just says that the whole way down. For the head, neck, chest, abdomen, pelvis, extremities, and posterior. You're just doing the exact same thing on the whole body. Like, I'm not tweaking. I swear. I wasn't trying to be funny. U penetrating ARP. U part. Penetrating airway respiratory pallor. Dang. Beat her up. God forgive me. I shouldn't be saying that. But blood and cerebrospinal fluid draining from the ear of a trauma patient. Yeah, that's not good. Blood on interior chamber of the eye. It is a sign that the eye sustained considerable force. Poor lady, I'm so sorry. A battle sign and other signs of brain injury. A patient with a battle sign, CT scan, the same patient. Alright, we have a stoma, a permanent surgical opening in the neck through which the patient breathes. I'm not gonna say it, but y'all know those freaking ads are like, hey, I was with the hell when I started smoking. Yeah, don't smoke, guys. Don't smoke. Or you get a stoma. It sucks. I've seen a lot of them. Okay, a tracheostomy. A surgical incision held open by a metal or plastic tube. I don't know what that is. Paradoxical motion. A movement of the parts of the chest in opposite direction to the rest of the chest. That's not good. What the heck? Paradoxical motion is a movement of part of the chest in the opposite direction to the rest of the chest during respiration. Yeah, that's not good at all. If you look, whenever it breathes, like whenever it gets big, the bones go in. But whenever it goes out, the bones come out. What? Yeah, I said that right. That's weird, bro. Distension is a. Oh, that's not the right side of the highlighter. Distension is a condition of being stretched, inflated, or larger than normal. Honestly, bro, I didn't know what that was, but like now it kind of seems obvious. Priapism is the persistent erection of the you know what that may result from spinal injury and some medical problems. Okay, so if your back breaks, the doctor shouldn't get weirded out if you have one, guys, because it's a real thing, I guess. Assessing a distal function, assessing breath sounds. Yeah. It's a distal function. Alright, so assess all your extremities for distal circulation, sensation, and motor function. Sensation, make sure like if I touch here, you're not like freaking out. Circulation, make sure like you can feel all the tips of your fingies. Motor function, you can do weird stuff with your fingers. Assess strength. Wait. One. Assess distal circulation and upper extremity. So first is circulation, then motor functions, and assess strength. Assess distal sensation. Finger, am I touching? Okay. Sensation is you like making sure they can feel. Alright, and then just pull their skin pretty much. I'm going to check circulation again. Make sure they can move their feet. Assess strength. Yep. Tell the patient what you are going to do at all the time. Expose any injured area before examining it. Maintain eye contact. Apply your spinal protocols. Pediatric examination. Their head is big. We got a picture of it. Head big. You already know. Oh, your boy don't got too much time left. Airway, chest, abdomen, pelvis, extremities. They have a different order. A detailed physical exam is the assessment of the head, neck, chest, abdomen, pelvis, extremities, and posterior of the body to detect signs of symptoms of injury. It differs from the rapid trauma assessment, only that it also includes examination of the face, ears, eyes, nose, and mouth during the examination of the head. Boys, you gotta do the thing with the thing. So look, scene size up, primary assessment, critical interventions and immediate life-threatening problems, patient history, sequence of assessment priorities. All right, repeat primary assessment for immediate life-threatening problems, provide critical interventions as needed, detailed physical exam, reassessment for life threats. Okay, what all you're doing is making a bunch of assessments, making sure that they're not dying. Chapter review. All right, that was the first mid-chapter review I've seen, and now we're finally at the chapter review. Kind of a long chapter. This is chapter 15. We still have 2 more chapters to go over, but I don't think we're going to get to that today. So, yeah. The patient without significant mechanism of injury receives a history of the present illness and a physical exam. Focus on the areas of the patient's complaints about the areas that you think may be injured based on the mechanism of injury. Okay. Gather a set of baseline vitals of patient history for the patient with significant injury of MOI, mechanism of injury. Provide spinal precautions. Yep. In the rapid trauma assessment, look for wounds, tenderness, and deformities, plus certain additional signs appropriate to the part of being assessed. After assessing the neck, it may be appropriate to apply cervical collar. Provide spine motion, restrictions, whatever you gotta do. After you have performed the appropriate critical interventions and begun to transport, the patient may receive a detailed physical exam en route to the hospital. The detailed physical exam is very similar in rapid trauma assessment. There is time to be more thorough in the assessment. Detailed physical exam does not have to take before the transport unless the transport is delayed. Okay. The detailed physical exam is the most appropriate for the trauma patient who is unresponsive or has a significant injury or unknown MOI. The responsive trauma patient with no significant injury or MOI will seldom require detailed physical exam. And we have a chapter glossary, preparation for your exam. Bro, this book is it's so good. But, it takes 6 months to read this book, and I have 6 weeks to read it. I'm already into week 3, which is why so much of this book is done already. But so much of it is left. We're in week 2 right now. We just took our second test. But yeah, life's going pretty good right now. Now that the study sesh is coming to an end. I don't know, bro. I kind of just want to lay in this hole and never come out. But you know what we are going to do? Since we have time. It's chapter 17. Chapter 16. Perfect. Alright, one outcome. Analyze the components of your approach to reevaluate patients in EMS scenario. It is important to observe. Wait. I'm not actually reading. But you have a reassessment and trending. What? Oh. Detecting changes in the patient's condition. That's all the reassessment is really. Trending is changes in the patient's condition over time. Yup. Observe trending during reassessment. Reassessment for stable and unstable patients. Bro, that's like the shortest chapter in the book. What the heck? But yeah, you want to get those reassessments in. You want to make sure those trains are nice, bro. Like, it's never too late, nor too early. No, you're probably a little late if they're dead. But you want to get that assessment in as fast, that first assessment in as fast as possible. Get the most important about the way. Then you want to handle all that sidebar. Because once you get there and your patient already finna die, you want to make sure they're good. Stabilize them. Get them going to the hospital. Get them stabilized. Keep them stabilized. And, go from there. Because once you see a trend, like if they're all the way up here and then they just start going down, and you're like, hey, we got to prepare to start giving this man oxygen so we can get him back to up here or he is going to die. You don't want a dead patient. It sucks. I say that like I've seen him. Reassessment is the last step in your patient's assessment. Yep, because you have other important things to do. You should generally reassess a stable patient at least every 15 minutes and an unstable patient every 5 minutes. Elements of reassessment include repeating the primary assessment, repeating and recording vital signs, pertinent parts of the history and the physical exam, and checking treatments or intentions of the performed of the patient. So yeah, you're just looking to see if the patient's condition has changed at all. We got some critical thinking exercises. Sick. All right, and then for chapter 17, which is the last thing we study before the test, we have a test on Friday on chapters 11 through 17. So, yeah. Compare public safety radio communication systems best. Evaluate various types of interpersonal communication. EMT with others. Generate written pre-hospital care. Report the portrayal of patient care. All right. So some terms I gotta remember: base station, cell phone, a drop report or a transfer report, a mobile radio, portable radio, repeater, telemetry, and watt. All right. Well, I've been recording for an hour and 1 minute. The boy has 20 minutes to freshen up before class, get all slick and nice looking for the classmates, Spray some Febreze on me because I'm not allowed to have cologne. And yeah, I enjoyed this, I may have just been talking to myself for an hour. But I hope that if and when whoever sees this, I hope that you enjoy this. I hope that you had fun, having fun. But yeah, your boy is doing fantastic. And I really just wanted to thank y'all for, staying strong, showing that love and support even while I've been out here. Keep me in your prayers, y'all. And I couldn't. Who would I be if I hit you with one of these? Okay. All good things come from God. If you want to look deeper into that, it's James 1:17. Dang, bro. Can't even hit y'all boys with the verse of the day, but God bless you. Wait. Hope you're having a good day. God bless. Wait. If you enjoyed, oh no. If you enjoyed, thank you for watching, and don't forget. Wait. Thank you for watching, and if you enjoyed, don't forget to like, comment, subscribe. God bless you, and have a good day. Oh my God, I forgot the outro words. Yeah, God bless you. Have a good day, and be safe.